I'll turn it over to you, Eric.
We'll be starting the webinar around 3 p.m. for those who are currently waiting. This is a recorded event. Just wanted to let you know. Your cameras and microphones will be off. And if you have any questions, if you could put them in the Q&A or the chat, and we'll do our best to answer them. And if you are here, if you could make it so we can see your first and last name, that helps with getting your CEHs. And ultimately, if you have multiple attendees, if you could ultimately email me, that would be super helpful too, and we'll make sure that their names get on the roster. And again, we're going to start around 3 o'clock. All right, folks. Well, thank you for joining us today. My name is Eric Wellman. I am the EMS Manager here at Maine Medical Center. Today, our topic of discussion is going to be enhancing transcutaneous pacing in bradycardic emergencies. Also joining us is Dr. Scholl, who will be running the background for us in the Q&A section. I have no financial disclosures. How are you, sir? But again, as Dr. Lewis put it very well, if you would like to give me some financial disclosures, I will not fight you on that. So today we're going to review a case study about false electrical capture and pre-hospital transcutaneous pacing by paramedics. Take a look at the assessment and management of symptomatic bradycardia, predominantly in adults. We will have some pediatric discussions also. We're going to identify best practices for the usages of transcutaneous pacing in the management of symptomatic bradycardia. And then ultimately, we're going to end with the best practices for handoff in the presence of transcutaneous pacing. In a recent edition of Pre-Hospital Emergency Care, a case study was published for false electrical capture in pre-hospital transcutaneous pacing by paramedics. This was a retrospective chart review done with a large urban transport agency, two of them, in fact. The data was collected from March of 2021 to 2023, and the group was including mostly adults over the age of 18, and anyone with a recorded heart rate of 60 beats per minute, and an attempt was made at transcutaneous pacing. It's actually a small study in the long run, but the primary outcome was determined by two paramedics reviewing the run sheets. So what they did was they trained two paramedics to look for specific criteria in the waveforms of EKGs to determine that the paramedics had identified a widened QRS segment and a tall, broad T wave afterwards. And this was their definition for this study of what's called true electrical capture. All data was reviewed using a CodeStat program. Neither of the evaluators could see what the other one could see. They could not see any data related to what was going on with the patients or what was going on in the sense of the other provider was saying for that. They didn't know any of the paramedics that were involved, or they had that all blinded to them. So ultimately, the goal was to make this as objective as humanly possible in that. And ultimately, if there was and both evaluators evaluated all of the cases, and if there were any moments where they disagreed on what the outcome should be, the primary author of the case was the ultimate decider on which way they should lean. So ultimately, the primary outcomes were if whether or not they actually had electronic capture with the criteria, but there were also some secondary outcomes that came about, changes in systolic blood pressure, some documentation of how mechanical capture occurs, and survivability scores of CPS and survival to admission were data that were also pulled out of that. So ultimately, the sample size here is actually really, really small. So there were almost 57, well, there were over 57,000 reports, transports over the 2 years in this, and that ultimately they were able to pull out 23 patients. So that's a really tiny population. It was only 0.04% for the review. So it's really a very small study. So it's more of a case study to look at. So the interesting number that they identified here was that the paramedics were able to identify electronic capture or had electronic capture in their patients. Out of the 23, only 4 of them actually had electronic capture, and 19 of them had what was called false electronic capture. We'll get into what the differences of those two were a little bit later. But what true electronic capture indicated was that these patients were actually being fully paced versus the other group, which may not have been having the best pacing possible. So additional information that was pulled on the median age by group was 79 for the group that was electronically captured and 73 for the false electrical capture. The false electrical capture group was a much larger sample of groups, so it had a much wider spread on ages and gender and sex. And we also, there's some data on what the group had for a previous medical history was included in here also. Additionally, if you look at this group, some interesting data here from this is these were the actual things that were done for the patient that was involved. So ultimately, what did they receive for treatments and plans? And you're going to note, I think there's something that's kind of stood out to me in this is if you look in the data for the true electrical capture group, there were no incidences of cardiac arrest in this group, but there were incidences of cardiac arrest in the other group. So that was an interesting piece to me on that. So almost all the people involved received some sort of medication intervention at some point during the pacing event also. So some of the outcome material that was interesting that they were able to pull out, and I'll talk a little bit about this in a little bit a couple later slides, but there is some interesting stuff here. One of the big things that stood out was that there was a noticeable systolic blood pressure change in the true electrical capture group. So that was a finding that showed that in people that had electronic capture, that was actually meaningful. The patient's systolic blood pressure rose. In the group where it didn't rise. Again, really tiny sample, more data is needed to be collected here. There were also some additional pieces that just could not be statistically analysis here, but the survival to admission and CPC scores were also some collected, and the recorded potassium values were also part of that. So one of the other pieces of this is that they were able to look at medical records for some, not all of the patients. So in some cases of the 23, they were only able to look at 16 records that were in the hospital. So again, this population got a lot smaller from this. But in the true capture group, they were able to identify 2 records that they were able to review. And in the false capture group, they were able to look at 14 records for those patients. And ultimately, here's some of the data that was pulled from that, is that in the true electronic capture group, those 2 records that they were able to look at survived to admission to the hospital, and 1 survived to discharge, versus the false electronic capture group, which showed that only 10 were able to only survived to admission and none survived to discharge. So an interesting statistic. So some of the limitations of this case study is that functionally, as I said earlier, this is a really tiny sample size. It's really limited to these 2 organizations. There could be some bias in it based on the fact that the organizations could have some issues directed, though the case study did discuss that they were successful in other endeavors and other markers for quality, like STEMI markers and things like that. So it's likely that were a proficient system. But again, small sample size, so you have to take that data in that sense. They were not able to look at outcome data for all the patients, so we obviously had that limitation also. And in their documentation itself, they did not have consistent reliability in pad positioning for documentation, where pulse palpation occurred, and ultimately the method of blood pressure measurement, whether it was non-invasive or if it was done with a manual BP cuff. So ultimately, also the primary author ultimately made decisions based on whether or not what the qualification was, who was the paramedic that was right in the decision making. So there could be some bias introduced there. Big thing is this is a subject matter that should probably continue to be researched, but there's some really interesting material in here that I think should catch all of our attentions as EMS clinicians. One of the biggest things said that if you look at this data the way they're laying it out and using their criteria, that less than 1 in 5 patients received appropriate transcutaneous pacing during the case study. So again, that means that a good amount of the patients did not get adequate pacing. Additionally, that several of the paramedics failed to recognize the inappropriate pacing. Now, information that wasn't readily available is if they had been trained fully in the mechanism that was used here, in this case, or that. So, but ultimately, what this case study did reaffirm is that if you received poor pacing, you had poor outcomes, which I don't think was a jump for any of us to make. So I'd like to take a moment to kind of take a look at symptomatic bradycardia in a large spectrum, utilizing some of our Maine EMS protocols, but discussing it just to make sure we review it so that we're all on the same page. Bradycardia has routinely been defined as any heart rate that's below 60 beats per minute in an adult. That's a traditional definition of that. In the recent years, AHA redefined symptomatic bradycardia to be less than 50 beats per minute with signs and symptoms of cardiovascular collapse. We also identify that in pediatrics, it's still 60 and below, and we have interventions for that. Again, the rhythm itself doesn't necessarily define the bradycardia. It's the rate of the rhythm that defines the bradycardia and what goes on there. So the big decision maker for those of us who treat bradycardia, and that is all of us, that's EMRs, EMTs, and AEMTs included, is the patient symptomatic or asymptomatic? And for those of you who have taken an ACLS course, you recognize that there's a pretty standard symptomatic bradycardia definition, which is bradycardia with the presence of chest pain, dyspnea, cyanosis, pallor, acute heart failure, pulmonary edema, altered mental status, any kind of syncope or fainting, and/or signs of shock or hypotension. So somehow the patient is not the heart is not pumping effectively, so therefore they're experiencing other signs and symptoms that go with that. Asymptomatic bradycardia means just a standard low heart rate with no complications to perfusion. So again, if you think about people who are exceptionally athletic, their blood pressure, their pulse rates are generally lower at rest than the rest of ours, so they could easily be at 40 and have no complications related to that. So when we look at when we arrive to a patient that has some sort of cardiovascular compromise that may be bradycardia, we want to make sure that we rapidly identify their level of responsiveness. And the key component here is that an unresponsive patient could be bradycardic. An alert patient could be bradycardic, and they are obviously treated in different ways. We also want to make sure we get a good idea of what their pulse and perfusion status are relatively quickly. So if you notice here, for those of you who are tuned into the American Heart Association, we were looking at the CAB approach, which is the CAB, checking circulation and then airway and breathing in these patients to ensure that they're there. Our priorities are to obviously perfusion first. So if you're confronted with a pediatric patient who is significantly bradycardic and has signs of poor perfusion or any of those additional signs that we talked about for symptomatic bradycardia, you are likely going to be initiating chest compressions and ventilations almost immediately. This is a major step that can have a major outcome change. So for our EMR and EMT providers, this is going to be an outcome changer that you can make for them. It's a little daunting to think about that you're initiating chest compressions on a person that is actually could be drawing breath and has a pulse, but this has been shown to help with perfusion. And I think the thing we want to remember in pediatrics, the leading cause of bradycardia for them is hypoxia. So we do want to take our next steps, which is to make sure we ventilate and oxygenate our patient, and we want to make sure that we get their oxygen saturation to as close to 94 to 99% as possible. If you have the availability, you'll want to collect an EKG and a 12 lead as soon as possible, and gain IV and IO access. Considering a fluid bolus initially could make some steps here. And then the biggest thing is ask yourself, why is this patient bradycardic? And bradycardia is a symptom in multiple areas. And we do need to remember that it is a symptom. It is not just by itself something that may be the only issue at hand. Something else is likely driving this. So think of bradycardia as a symptom, not just a cause. So things that do cause bradycardia, and there's an extensive list here. Again, I talked about with pediatrics that hypoxia is a leading cause of bradycardia in pediatrics, and is probably a significant cause in many other forms of bradycardia for adults too. But as you work down the list, you can see the myocardial infarction, the failure of the sinus node, AV blocks, potassium changes, calcium changes. Neurogenic shock can give you a form of bradycardia. Decompensated shock, so when you get past the phase of the elevated tachycardias, you can go into bradycardia as the system starts to fail. Immediately after the return of spontaneous circulation, you can get a bradycardic rhythm from the damage to the heart as the heart recovers. Many toxins can lead you to bradycardia. We'll get into that in a moment. Hypothermia, hypothyroidism, Brash syndrome, which is a mixture of renal failure, Usage of AV node blockers and hyperkalemia can lead to bradycardia, and intracranial pressure can give you bradycardia. So that's a pretty big differential diagnosis range that could be the cause of your bradycardia. And again, you want to make sure that you have an idea of what's causing your patient's bradycardia before you begin to treatment strategy. So ultimately, the cardiogenic version of bradycardia, when we think it's in this realm, predominantly is treated with oxygen. And again, a commonly overlooked step is to get oxygen on patients early and treated with it. And for many cases, it may be the piece that actually solves the bradycardia because it takes away the hypoxia. Again, we talked about it earlier, but pediatrics, we're going to talk about chest compressions if they're below 60 and they have poor perfusion. And then we're going to move into our IV pieces. So we can treat bradycardia commonly with atropine, which is a parasympathetic blocking agent. So what it does is, an anticholinergic. And what it does is it basically tells the heart to stop receiving signals from the vagus nerve, which then increases the heart rate. Or at least that's the intent. And if that's not an option for pediatrics, we can also use epinephrine. Epinephrine is indicated for pediatric use. And then they would, if that did not have the effect you were looking for, you would go back to atropine for those. So those are a couple of the frontline options for that. The reason we're here, transcutaneous pacing. So pacing is another option for the treatment of cardiogenic bradycardias and can be used in other types of bradycardia. But ultimately here, you want to follow your manufacturer's recommendations for your device for what rates and milliamps, and every clinician seems to have a different setting that they use. But generally, a rate between 60 and 80 for an adult is generally a good place to start. And your milliamps, there's several methods. There's the method of starting low and going high, so increasing your milliamps as you go, or starting high and coming down, and when you lose capture, going back up. Again, there's not a large amount of literature that says which one is more successful. So using the method that you're most comfortable with is the way to go. One of the key things to remember about transcutaneous pacing, if your pacer is not set to basically just be a constant pacing setting, you may have to have your EKG leads in place, especially if it's an on-demand pacer, in order to get the pacer to do what it needs to work effectively. So don't forget those EKG leads. You can use a pacer in pediatrics. I think the key thing to remember is that they are very pediatrics respond well to the dealing of dealing with oxygen. They deal well with the chest compressions, and they do respond very well to medications if those medications are going to do what they do. The big thing to remember is as people get older, transcutaneous pacing can, and in our pediatric groups, can lead to burns. So prolonged things. So anything longer than a half an hour for some of these cases could actually lead to burning your patient. So just be mindful of those factors, especially if you have long distance transfers that you have to do. Generally, evidence is stronger for an anterior posterior placement. So that's on the front on that. And I'll show you some diagrams here in a moment. You want to make sure you obtain both electrical and mechanical capture. So electrical being on the EKG, mechanical being some form of pulse, being able to be palpated along with some other criteria, which we'll go over in just a moment. And then once you have that capture with mechanical capture, you do want to increase your milliamps, just 10. It's a general recommendation. Most instruction manuals have that in there also as a safety piece to make sure you stay with capture. And ultimately, once you have started pacing someone, you should probably stick to a pretty regular piece of 2 minutes of maintaining that capture, and both electronic and mechanical. So if you are using an automated cuff, making sure that you can set that to a 2-minute interval to get a blood pressure every 2 minutes, so you can have that recorded on your documentation. So for pad placement, one of the things you want to look at is as we discussed earlier, so this is a study from the AHA that showed, and again, small sample size, this was probably around 20 patients. that they, actually 19 patients, they looked at AP capture rates versus anterior lateral capture rates in adults. And as you can see here, that AP had a overall 78% capture rate, and anterior lateral had approximately a 42% capture rate. So you can see that AP has a substantial benefit here. It works better in females than it does in males, but just so you understand, in this study, the female group was a substantially smaller group than the male group. The goal is, when you do place the pads too, is that it's in the first slide you can see on the left, the placement on this one, when they're doing the anterior to posterior with the back being on the bottom of the slide, that they actually placed it over the sternum and over the spine. So that's not what the goal is. The goal is to get it over the ventricle here, if you look at the right side, and have it directing through that way. So again, AP placement is substantially more successful than AL placement, at least in some of the data that's out there. And if you don't get capture by about 130 milliamps, you should start thinking about using a different angle or a different placement of the pads, much like we do with defibrillation. Thinking about that, if you were doing A and P, maybe it's time to go to anterior lateral, or if you were on anterior lateral, going to A and P, or maybe even just shifting the angle a little bit to get a better fit. But also, the other thing that you really may want to consider is that about 1 in 5 patients may not respond to transcutaneous pacing, so it may not be a viable option for your patient. If pacing is not an option, epinephrine infusion may be the next option, and even with pacing, it may still be an option. So ultimately, you can, your medic can introduce an epinephrine infusion with the goal of getting their systolic blood pressure up to 90 or a MAP of 65, and that's another option in your toolbox. The other key thing to remember is that poisonings and overdoses can lead to bradycardia. Probably the more common of those that you'll encounter is probably an opiate overdose, that with the hypoxia you can get bradycardia and ultimately cardiac arrest, and that the usage of naloxone may be your tool for managing the bradycardia in this case. Our goal stated to be return of spontaneous respirations. Another poisoning that can cause this is beta or calcium channel blocker overdoses. So again, we can use calcium gluconate in order to offset that. You may start out treating a beta or calcium channel blocker overdose functioning much like you would in with a standard symptomatic bradycardia, and go the route of atropine first and those. But if you identify that it is a beta or a calcium channel blocker overdose, a calcium gluconate infusion would be very helpful. Ultimately, with the also the types of overdoses, beta blockers tend to cause hypoglycemia. Apologies. Calcium channel blockers tend to cause hyperglycemia. Again, that may be a piece of information that helps you along the way. As that in pediatrics, beta blocker overdoses generally do lead to significant hypoglycemia, and you may see it in adults also, but predominantly in pediatrics. Another one that you don't see that often, but can be there, is that if they are exposed to a nerve agent or an organophosphate, you may see what's called the killer bees, which is bradycardia, bronchospasm, and bronchorrhea. That's after the sludgeon has taken effect and as you move along. Again, this is the Maine EMS protocols and recommendations for the usage of atropine and 2-PAM that are included here. So this is another route where you may encounter a bradycardic rhythm. Again, the usage of atropine and 2-PAM are the indicated pieces here, not necessarily transcutaneous pacing. So as we've looked at how we would encounter bradycardia, we want to talk about some of the successful strategies for transcutaneous pacing. In the case study, one of the things that they noted was what they called true electronic capture versus false electronic capture. And in their study, what they recognized was on the left-hand side of the screen, you'll see a wide QRS, but no T wave present. So it looks much like you can see a small pacer spike, and then it looks like the patient has some sort of ventricular tachycardia afterwards because they have that wide QRS. But you will note that has no T waves present in this, versus on the right-hand side where you take a look, and the patient has distinctly has a QRS complex and then has a T wave. Recognizing that this was what differentiated the false from the true with the usage of this, and this was the group that did substantially better with outcomes. And this is just a little bit of a closer view if you weren't able to see it before, but that clear T waves are present here. Additionally, and I like to bring this up because I didn't learn this until later in my EMS career as a paramedic, that there should be a linkage between the pleth wave on your monitor and your EKG if pacing is successful. That when you have good electronic capture, good mechanical capture, that your pleth wave on your O2 sat is actually matching the information that you see for your EKG with the pacing here. And as you can see, this is a good example of where this is, and that you are more likely to be inclined to have a successful capture of the patient. What most of us were taught was to do a pulse check. And ultimately, the three major areas that are generally done for a pulse check are anywhere from the femoral to the carotid. What we need to understand is that the femoral is probably the best location for a pulse check because it's the furthest away from the pacing. It's least likely to be affected by the actual electrical impulse that is generated. And again, additionally, this is probably the hardest one to get to or the most unfamiliar to us because it's not the one we check every day. But again, it is the one that is most likely to indicate both good mechanical capture and electronic capture. The radial artery can be less effective. There is some evidence that the right side may be a better choice than the left side because of the way the electrical conduction actually works. And everything. But again, radial artery is probably still not the best choice. Femoral is still going to be your thing. And the carotid artery, almost all the electronic documentation for the usage of most of our cardiac monitors say that this is not the place that you should be checking a pulse. And a lot of that is because it's so close to the pads itself that you may actually be getting the pulse you may be feeling may actually be the electrical conduction causing spasms in the actual artery itself. So remember, the femoral is the artery that you'd like to use, not the carotid. So again, just a quick review. The best practices here are to do anterior, posterior pad placement. Look for wide QRS complexes that include a T wave. Think bundle branch block, not ventricular tachycardia. The pleth wave on the oxygen saturation monitor matches the pace rhythm. I talked about this a little bit earlier, but your systolic blood pressure is notably increased with successful electrical and mechanical capture. In this case study, the median change was 40 millimeters of mercury. So they went from a blood pressure of 60 systolic to a blood pressure of 100 systolic. We do know that pulses can be complex to detect even by experienced clinicians. So again, femoral pulse, but again, you may if this is the only method that you use to determine that you have mechanical capture and all things working appropriately, you may get a false positive or may misinterpret something. The other recommendation, and I'm going to go with what Dr. Lewis started with for us last session, is that creating your own checklist based on your cardiac monitor defibrillator for how you want to approach transcutaneous pacing is probably a strong suggestion that would work exceptionally well, so that you know the steps that you want to take, and including these pieces up here about pad placement and changes that can be collected for the patient. Finally, nothing is good unless you document it well. And the key documentation that you should have for the usage of a transcutaneous pacing event or anything that has to do with bradycardia that may have not been that may not have been paced, but you want to make sure you have a EKG rhythm and rate that led you down the path of bradycardia. So, we had a 3rd degree block, we had a 2nd degree type 2, was assigned as Brady, but whatever that was and what those rates were. Any medications that you administer, time, dose, and response to those medications. If you are using transcutaneous pacing, make sure you include where the pads were placed, how much rate, what the rate was, the milliamps that were used, what you ultimately got to for a capture setting, pre and post EKGs. So making sure if you have those, that you are including them in the documentation. Any events that occurred during the pacing. So did you lose capture? Did the patient go into cardiac arrest? Important things. Patient weight is important, predominantly in pediatrics, but gives you an idea, gives a better picture of what kind of patient you were dealing with. Patients that are morbidly obese may have difficulty being paced. Blood sugar plays a big role based on the poisoning incidents or the reason why your patient might have altered mental status in addition to their bradycardia. Did you use any sedation or pain management? Again, if they're alert and they're being paced, it's an exceptionally painful event, but also even if they weren't and they come out of it, they'll probably need some level of sedation or pain management. And then your vital signs should be recorded in generally 2-minute cycles once they begin on the pacing piece. It's a good way to make sure that you're staying abreast, and especially if your patient is unresponsive when they're being paced, this is a great way to make sure that you still have all the functions working the way you want them to. Finally, with best practices, you do want to make sure that you train frequently on this skill set. Any new clinician that comes into your service should definitely receive a comprehensive service level training in the usage of the cardiac monitor that they're going to be doing this on. You should make sure that they can identify bradycardic and symptomatic bradycardia in both adult and pediatric populations. And then ultimately, you should probably run them through some form of scenario or simulation that shows that they can operate the pacemaker, but also can make the decisions related to how they should be pacing and what electronic capture versus mechanical capture looks like and those things. And again, annually, you should probably be reviewing these skills, because we should remember that this, just from the data that we saw in the case study, these are probably a fairly low frequency performed skill set, but have a lot of high risk to them, because if it's not done appropriately, the patient may have a negative outcome. Finally, we'd like to take a look at the patient handoff piece. So it's sometimes one of the things that we hear is that when patients arrive to the ED is that during the handoff, there was some sort of event where the patient came off the pacer itself. So the pacing pads were taken off, they were disconnected from the pacer or anything of that nature. And these are some of the comments that are made over the time, that the emergency department ripped off the pads. When we entered the critical care room, they didn't listen to us, or the patient was in cardiac arrest and they didn't know, and the patient arrested when the hospital took off the pads. So these are some of the events that happen there. So we can successfully navigate this pretty well with a few, I think, simple steps. So before we engage as EMS providers in the handoff procedure, there's a couple things that we should do as we're getting to the hospital, arriving, and getting ready to walk through the doors. We want to make sure that we've determined our patient's level of responsiveness again, and we want to take the time to do this. Like, where are they on that scale, especially if they're unresponsive? We want to check our EKG and look to make sure that we still have electronic capture on our monitor. If we don't, we need to figure out what's going on before we move. Oxygen saturation, so check your pleth wave, matches your EKG. Check that femoral pulse to make sure it matches the EKG, and then what's your blood pressure? Because if you have those things going in, you're probably in a lot better place. If you haven't checked them in a little bit of time on arrival at the ED, these are things that you're going to want to know before you go into that room. The other one is, obviously, we've all seen the mess that can sometimes occur with wires being wrapped around each other and such, is that you just want to make sure that you have disconnected all your lines appropriately and you're not entangled and everything. And if you do need to do these things, make sure you make that clear when you arrive in the handoff so that things don't happen. The handoff is one of the most critical areas in medicine that is probably the area where the most harm can happen to a patient, because you're going from one clinician to another. Care is changing hands. Most of medicine has identified this as probably one of the most dangerous areas for that day, when a physician hands off a patient to another physician, a nurse to a nurse, or an EMS provider to a physician and a nurse, or any of those places. That's a place where a high risk event is occurring. There are many great steps to deal with the handoffs. There's the minute timeout system. There are dedicated SBAR communications or miscommunications that can occur. There's all sorts of formats. One of the things that we do know is that has to be established by the location where the handoff occurs, and all parties need to be involved in the decision making behind what the best way to make a handoff is. But when you have these moments, you want to be respectful of everybody in the care team. That's both the EMS providers and the hospital providers. You want to make sure everybody's present when you do the handoff that needs to be, and such. And if you feel that an option that's available to you is subtly standing between the EMS stretcher and the hospital stretcher, is a good way to slow people down. If things are not going well, people are rushing, they're not communicating, that is a good way to keep the patient in place in that. The other piece is one, finish your slides. That's always a good idea. But you want to make the monitor visible to everyone involved, because one of the biggest things is that we put our monitors are designed to be hung on the back of our stretcher, but putting the monitor in a way that people can actually see it may help with that process of people understanding that you do have a patient who is being paced, and that they need to be, that needs to stay in place until everybody's all set. Some of these experiences are always vastly successful for people, and some of them sometimes have some moments where pads do get ripped off, and that was not the intent of anyone. When you do report, make sure you're getting the important information out first. You want to make sure they understand the age and sex of a patient are important to identify them. Location of the emergency, where do they occur? Again, you may be the only person that relays that information. They were coming from home, they were coming from an assisted living facility. Ultimately, what the chief complaint was that brought you to their side. What kind of onset they had, critical exam findings. So again, as you think about this, why do you have transcutaneous pacing running for this patient? Any initial EKG rhythms and rates that made you go down this route? What were the things that you brought to it? They had evidence of ingestion of beta blockers, those types of things. A reported vital sign piece. Again, what were the vital signs that drove you to this decision? And what are the vital signs now that have been stabilized or have not been stabilized? Include oxygen saturation and blood glucose, and then ultimately any treatments you rendered. So we provided atropine, we gave calcium gluconate, and we did some transcutaneous pacing. All of that wants to be part of that handoff. Leave room for questions, so that that people can fill in information that you may not have provided them during that time. That's always a good time to have the dialogue with the physician. So ultimately, my hope is that after hearing this discussion, that you've taken some interesting information out of this. One, bradycardia is, again, it's a symptom that people have. It's not generally the only thing they have. We have to search for that cause. We want to make sure we're in the right place with what's going on. When you do place pads, we want to place pads in the AP placement. That's going to be the best placement for patients. Again, you can use anterior lateral, but AP is the best. Again, it's probably harder to put on, but it is the right one. Remember that 1 in 5 patients may not respond to transcutaneous pacing. That number comes up a few times. And that if you are going to pace, that you do need to have electronic and mechanical capture, and that is defined by a QRS complex with a T wave after each pacer spike, a pleth wave that matches the paced rhythm, a femoral pulse that matches the paced rhythm, and evidence of systolic blood pressure rise. If you have all 4 of those, you likely have a successful transcutaneous pacing event. Ultimately, Also, before you come into the hospital, make sure you've assessed the patient one last time. That will prevent issues of patients that have gone into cardiac arrest in the ambulance and then brought into the ER that way. So you're keeping a constant monitoring on that 2-minute cycle, so that you're making sure those patients are well maintained. Have a nice set of reference links here. Matt, do we have any questions in the chat?
Let me just check again. I don't know that I had seen any. Nope. Looks like there are no questions in the chat right now. Thanks, Eric.
Excellent. Excellent. I've included some reference links. I will email out the reference links to you. There's some great podcasts on this and some other websites that have some great information if you're interested in further in this. I would love to hear your thoughts on the talk. I have broad shoulders, so if you didn't think it was great, I'd love to hear that and how I can improve it for the future. And if you thought it was great, I'll listen to that also. I do really would like to thank everyone for attending today. We're excited to be doing these 1-hour webinars for you in the next period. And additionally, if you are interested in the next webinar, Dr. Joe Minicello, who's the chief resident for Maine Medical Center Emergency Department, will be presenting on sepsis on July 9th at 3 p.m. also. You can find a link to the registration page there. And I'll leave that up for a minute. So if you need a little bit of time to find that. But we greatly appreciate you coming to the webinar, and we look forward to seeing you in July. Again, if you have any questions for me, you can always reach out. And once again, thank you for attending, and we hope you have an enjoyable day.